Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt. I am the managing editor for VBCExhibitHall.com, and I'd like to welcome you all to today's live webinar hosted by CarePort, which is powered by WellSky, and it is titled Harnessing Data in Value-Based Care: How Atlantic Health Drives Success in Shared Savings Programs. Very excited about this presentation today. Really, we had a lot of registrations, so people are very excited to hear from these gentlemen today, and glad to have you with us. A few items of note before we get started. I wanted to let you know that just like a regular webinar, not a Zoom meeting, you've joined in listen-only mode, so you don't need to worry about muting your microphone or your camera or anything like that. We can't see or hear you. But also, we are recording the session today. So what's going to happen is when we're done, I'm going to send everybody who registered, even if they're not in attendance, I'm going to send everyone a link to the recording, to where you can actually see the recording, and you can also download the slides from today's presentation as well as connect with them there. So I'm going to send everyone a link after the presentation is done. Finally, we want to hear from you. We're going to have a time for Q&A, so please ask any questions that you have for any of our speakers, and we're going to get to as many of those as we can. Again, we have a huge audience today, which is amazing. But we're going to get to a lot of questions during the allotted time. If we don't get to yours for some reason, we will make sure to respond through email later on. So go ahead and ask your question, even up until the last second you can ask. And you don't need to wait until Q&A in order to do that. Go ahead and ask at any time. And the way you do that is actually on your control module, you have a little place for questions. It's not the chat, it's a little question module. Okay, without further ado, I wanted to briefly introduce our speakers today. We have Dr. Mark Calderon, who's the Medical Director of Integrated Care at Atlantic Health. I've been practicing that pronunciation all morning, and I butchered it for the live presentation. So. That's all right. And we also have Mr. Thomas Martin, who's the Director of Post-Acute Analytics at CarePort. So welcome, gentlemen. I believe Thomas is going to kick us off. So welcome, guys.
Okay, thanks, everyone. And thank you for joining us today for our webinar. Again, I'm Tom Martin, Director of Post-Acute Analytics at CarePort. And it's my responsibility and my team's responsibility to generate all the analytics and predictive models and quality metrics that we are sharing across CarePort's various solutions. And today I'm very fortunate to be joined by Dr. Calderon, Chief Medical Officer at Atlantic Health. And Dr. Calderon has a proven track record of successfully using data and analytics and population health management to help drive quality improvement while controlling cost. So today, our plan is we're going to be sharing with you the Atlantic Health experience and their strategy as they have been using CarePort's tools to manage 2 different ACOs and build out and maintain a highly performing network of skilled nursing facility providers. So I think Dr. Calderon will mostly be the star of today's show, but I'll be interjecting from time to time to call attention to some of the numbers that we think really illustrate the success Atlantic has had in undergoing this work. And I'll be sharing some of the characteristics of data that, while it's not the data that has generated all the success, but it certainly helped. So with that said, I will call attention that, at CarePort, we have various solutions that we offer to help with care transitions into the post-acute space. Today, we are really going to be focused on CarePort Insight. That is the tool in which we surface all of the quality metrics on the Atlantic Health populations and the providers where they are receiving care. So we're just focused on that today. And then, one more thing, before I pass it over to you, Dr. Calderon, that I'll call attention to, and I think that's just to reiterate the importance of undergoing these efforts to manage post-acute care when you're in one of these value-based care arrangements, whatever arrangement that may be, ACO, bundle, Medicare Advantage, whatever it is. And I'm probably preaching to the choir with this audience today, but just as a reminder, I will share two stats with you. One is the percentage of spend that is spent in post-acute care for your typical bundle, and that's 39% of your spend. So while the bulk of the spend, yes, will be in the inpatient care setting, a huge chunk of it is going to be managed in the post-acute care space, okay? The second thing I'll share is just how much unexplained variance there is in patient quality and cost in the post-acute care space. And what I mean when I say unexplained variance, I mean that after you control for patient characteristics and you control for market, there is still a lot of variance in the type of care a patient receives based off which provider they go to. And so I will share two findings from a paper that came out just this last August from the National Bureau of Economic Research. And in this paper, I think these economists, found some compelling evidence to just sort of demonstrate this point. And that is that if you compared a 10th percentile skilled nursing facility, and by 10th percentile, I mean, or they mean a nursing home that is very efficiently discharging patients home back safely to the community in a short period of time. And you compared that to a 90th percentile skilled nursing facility, or a SNF that on average is keeping a patient much longer in the facility before discharging them back home, you'll see that between that 10th and 90th percentile SNF, there's about a week difference in how long that patient is receiving care. So that's the same patient, the same market, a week difference in care. So we're talking like $3,000 to $4,000 in spend, and a patient spending an extra week in a facility when they could have been discharged home safely. So just to, I think that stat is very much written like an economist, so you have to interpret it, but a very compelling stat. And then I think the conclusion of the paper, which I also find a little humorous because I know it's much more complicated than the way they wrote up their conclusion, but results point to potential for substantial gains through policies that encourage reallocation of patients to higher quality SNFs within their market. And I think that's a very nice economics way of addressing some of the great work Dr. Calderon has been doing. And so with that, I'll pass it over to you, Dr. Calderon. Oh, and I'm sorry, I'm not passing it to you just yet. We want to do a poll question first. And that poll question is, I'll ask the audience, and Garrett, maybe you can pull this up. How many of you in the audience today have experience with profiling a market and building a high quality network like this?
Okay, I did pull that question up, so we're waiting on the responses to come in.
Okay.
And are you able to see that?
I cannot see it.
Okay.
I cannot. So have to.
That's all right. We'll give it a couple more seconds. All right, I think most of the answers have come in, so I'm going to go ahead and close that out and share the response here. Okay, it is pretty neck and neck. We have yes is 51%, no is 49%.
Okay, good. That's a pretty good number that have some experience doing this. So let me.
All right.
Okay, Dr. Calderon, I'll pass it to you.
Great, thank you, Tom. So first of all, just to introduce myself again, Dr. Mark Calderon. I'm the Medical Director for Integrative Care at Atlantic Health. Prior to that, I'm a family physician by training. Prior to that, I served as the Chief Medical Officer for our ACOs. So I've got quite a bit of experience in the value-based space. Just a little bit about Atlantic. First of all, we are home to the 7 hospitals. We have a workforce of over 18,000 members. We service half of the state of New Jersey, including 11 counties and over 5 million people. Our clinically integrated network, which is reflected in the top table there, is over 3,400 care providers supporting both in North and Central New Jersey. It includes 2 accountable care organizations. We have Atlantic Accountable Care Organization, which is made up of hospital-owned and leased practices that sit on an Epic platform. And then we have Optimus, which is our ACO of independent practices, and they are on multiple EMRs and versions of EMRs. So we've got two distinct ACOs. Combined, we manage over 64,000 MSSP lives. We have a total number of over 437,000 attributed lives in our ACO in totality. And we've had really outstanding results with regards to quality and some success in shared savings, which we'll see in the next slide. So just a little background on this slide. So Atlantic has really leaned into value-based care for quite a while now. We entered the ACO space in its inception, and we've had a tremendous amount of success in that space. For most of the time, we have been in upside-only programs. As a result of that, we've been able to save Medicare over $168 million. We've been able to distribute over $64 million in shared savings to our ACO participants. So we're very excited and proud about that. But we've come into a sort of reflection point, if you will. We are seeing more and more challenges, greater push into value-based risk. So again, historically, our success has been in just upside-only programs. Now we're getting into value-based risk. So that's a bit of a game changer, because if you are not managing your budgets effectively, you have to write a check, and nobody wants to obviously write a check to CMS. We also have opportunities not just on the ACO side, but on the hospital side as well. So my role is not just to focus on the relationships with the skilled nursing facilities as it relates to the ACO, but also how it relates to and how it impacts our hospital system. So we're involved in bundle programs today. Right now we are doing CJR. We've done other advanced BPCI models in the past. And as you know, if patients are readmitted in those programs, it can blow up your bundle pretty quickly. We also are responsible for those patients that are part of the Medicare readmission reduction program. And that, in a sense, is also risk, because you're not going to get reimbursed for those patients. CMS has also signaled that they are going to, in all likelihood, expand those diagnoses that make up the readmission reduction program. In addition to that, the voluntary bundle programs that exist today will also, some of them will become mandatory, just like we saw with CJR. So you need to have a strategy in place to make sure that you're effectively managing your post-acute space and that you're reducing readmissions. And really the way to go about that is through data transparency. And we'll move on to the next slide. So just a little bit about how we influence change here. So my approach is very broad. My goal is to impact readmissions in the Medicare space, period. Whether they're Medicare Advantage, whether it's fee-for-service, whether they're part of our ACO, whether they're part of a bundle, because I'm really more interested in changing behavior and how we address readmissions in totality. We have also have more of a tactical approach around those patients that are in our risk programs. But my goal is really to impact behavior, not only on the part of the skilled nursing facilities, but also on our hospital discharge planning team, because they impact the way patients get transferred to a skilled nursing facility as it relates to communication. So it's engagement of the SNFs, engagement of the discharge planning team, and so we'll talk a little bit more about that, how we use collaboration, again, data transparency, and electronic and clinical integration. Next slide. So these are the goals that we're focusing on. So first of all, it's establishing a high-performing network. So we've got 27 skilled nursing facilities that support our 5 legacy hospitals. We also have a pediatric hospital and we have acute rehab, but our 5 legacy hospitals is where I focus my attention on. We have 27 facilities that are selected based on their performance, and we'll talk a little bit more about how we select those facilities. I meet with those skilled nursing facilities on a regular basis, bi-monthly, to review metrics, to identify best practices, to identify any challenges that they are experiencing as it relates to how patients are discharged to their facilities, and as well as express any challenges that we are experiencing from those skilled nursing facilities. So it's an active conversation. We meet not only with those 27 facilities that are in our network, I also meet with, on a regular basis, our high to moderate volume facilities that are not in our network, because they are very much interested in becoming part of it, and we want to keep those facilities engaged. And as I identify best practices that I learned from one facility, I share it with all of them. Improving clinical integration. So we have Atlantic Alliance physicians, we have employed physicians that do SNF work, we have independent physicians that do SNF attending work. And historically, they really haven't gotten anything in the way of data to show how they are performing. So we've been able to leverage the CarePort Insight tool to help us do that. And the other focus on integration is also with regards to our home health program. So we have our own home health agency, we have our own hospice, and we want to make sure that we have that continuity. So if we do have a patient that's in the skilled nursing facility that needs home health, that needs hospice, that the SNF is supporting us, supporting our system by using our home health agency. And then finally, throughput. So this is kind of important because right now we are experiencing challenges of getting patients to the skilled nursing facility for a variety of different reasons. Some of them are self-inflicted on the part of the hospital. Some of them have to do with the SNF, and we'll talk a little bit more about that. Next slide. So the first thing I wanted to review with you folks is how we established our high-performing network. Now, you could take there's a variety of ways that you can approach this, but this is the way we elected to do it. So historically, my colleagues had a very laborious process of collecting binders of information and asking for policies and procedures and doing a lot of busy work with the skilled nursing facilities. And in thinking about this, they really are a heavily regulated industry, probably after nuclear power plants. They're pretty regulated. So for us to put in a process and step to do additional regulation didn't seem prudent. So I wanted to simplify that. I wanted to be able to keep things different. So we had a couple of mandatory requirements that are, you can see in the box on the left there. So we have a intent to collaborate agreement. It's a SurveyMonkey document. It basically just asks them, are you going to comply with our request for data to allow us to participate in your UR rounds? Are you going to use our logo per our requirements? Those sort of things. It's not a contract. We have no contracts with our skilled nursing facilities. The other thing I wanted to add is we also don't own any skilled nursing facilities. So these are all independent facilities that I'm going to be talking about. So we have our intent to collaborate survey, and then we have an electronic integration requirement. 2 components. One, they have to connect with us through Epic. So Epic is our hospital platform, EMR platform. It is the means in which we communicate to skilled nursing facilities our need for a bed. CarePort also has tools to help support that as well. We elected to utilize Epic. And then, of course, it also provides the skilled nursing facilities with the clinical information they need to help take care of the patient. What was the patient's hospital course prior to arriving to the skilled nursing facility? So that was the first step. The second step, they have to connect with us through CarePort. The transparency of data is a must when you are working with skilled nursing facilities. You cannot rely on claims data from your ACO reports that come in 3 months later, then add on an additional month for processing that. You really need to have real-time information. And so we've asked any skilled nursing facility that wants to be even considered for the high-performing network, they have to connect with us through CarePort. And I can tell you that out of the, I don't know, 4 or 5 dozen skilled nursing facilities that we've connected with, 1 refused. That was it. And I'm still working on that 1 facility that refused. So, and if they're on, if your skilled nursing facilities are on PCC, the connectivity is pretty easy. But even if they're not on point-click care, they can, they're still able to connect. All right, so that takes care of the mandatory requirements. As far as scoring is concerned, we look at 3 scores. They're all 5-star weighted scores. The first thing we do is conduct a collaboration score or a collaboration survey amongst our team members. So these 3 scores kind of mirror the triple aim, if you will. So we look at customer satisfaction, us being the customer in this case. You know, how easy is it to work with the facility? Do they allow our team to participate in UR rounds? Is there timely exchange of paperwork between the facility and our post-acute liaisons? Do they meet with me on a regular basis? So it almost seems like every facility should get 5 stars, but that does not always happen. There's a lot of turnover in some of the facilities that we work with. So meetings are missed. We're sort of starting from scratch as far as educating them on what our approach is and our process is. So not every skilled nursing facility can get 5 stars. Then we look at the quality score. So the quality score is really the score that comes out of Medicare Compare, which CarePort pulls all of that information for you. And what we've made a decision about as far as quality, so historically we were using the overall score for to assess the quality of the skilled nursing facility. It's also the score that we would put on our brochures when we were having conversations with patients about selecting a skilled nursing facility. But after meeting with the SNFs, I learned very quickly that that overall score can be adversely impacted by their survey score. And a skilled nursing facility can, even if they've made all the corrections to whatever the issues were on that survey, their overall score can be tagged for years. So we just didn't think that was a true reflection of quality. So we made the decision to use the quality component of their overall score. But again, CarePort has a quality score that you can leverage that as well. So you don't have to use the Medicare Compare data. And then finally, the value score. And this is a metric that we calculate based on the facility's readmission rate and their average length of stay. And all scores are equally weighted. Next slide. Just a little background here as far as, I'm sorry, my computer just timed me out here. Hold on.
We can still hear you and see you, so.
All right.
Cue up the holding music.
Sorry about that. I hate when that. So just wanted to give you a little background about the value of engagement, the value of data transparency. So prior to me taking on this role, we had a very large skilled nursing facility that has multiple facilities throughout the state that were never part of our high performing network. Their approach was really not to engage with us. It was more about, driving revenue. And it is a challenge because skilled nursing facilities are based on the traditional fee-for-service model, which is counter to value-based care. And so, part of the whole engagement is getting them to understand what our challenges are and how can we work together in exchange for, more effective management of the patients, readmission reduction, lower length of stay. We can leverage more patients to your facilities. So we had that very large network that just refused to sort of play ball. I met with them. I met with them again. They were actually one of the early adopters of CarePort, so their data was already in the system when I got access. And we exchanged data. We looked, we tracked and trend them and said, "This is how you're doing. Yeah, I know you want to be in the network, but here's how the rest of your colleagues are doing, and here's how you're doing, and you still have some work to do." Fast forward a year later, when we reevaluated our network, which we do on a biannual basis, they not only got one of their facilities in, they got two of their facilities in. It's the first time it's ever happened. And they are so excited about it. Now they're working to get other improved performance in some of their other facilities so that they can get them into our network. Just one other note about this. We had one facility that we took off of our network, a facility that was in the network for a long period of time. And I still continue to engage with them. I went through all of their metrics, showed them how they did on their survey, on quality, on their value score. And sure enough, they started to improve. And if I was to establish the new network today, they would be back in because they're adhering to the performance. So some folks didn't take us seriously and they got knocked out and are now working back to get back in.
Great. That's great, Dr. Calderon. Thank you for that. I think next I wanted to talk a little bit about, some of the data you used, Dr. Calderon, to determine that network, some of the characteristics of that data and why it, was so successful. But first, I want to ask the group, and I guess this really pertains to those of you who have done this sort of provider profiling work before. So Garrett, could you launch that other poll question? And what we'd like to ask is, what type of data sources have you used to profile post-acute performance?
Okay, I'm getting that up. One moment here.
Cool. And while you're pulling that up, I think it's multiple choice options here. And we had 4 large groups. And I know there's so many different data sources, but it's really, claims data, the lag claims data on your patients, any public domain data, like a CMS 5-star rating, any data you're getting real time from an EMR. And then our last group, and I can't see the polls, was
non-standard.
Any data non-standard that you are collecting directly, either a survey, a questionnaire, an Excel spreadsheet. So just curious, what type of data sources did you use when you profiled quality?
Okay, the answers are still rolling in here, so we'll give it just another couple seconds. And again, this is multiple choice, but you can choose multiple answers. So
yeah, right.
if multiple apply to you, go ahead and select the ones that do. Okay, I think we're pretty much have everything in. All right, I'm going to go ahead and close out this poll here in 5, 4, 3, 2, 1, and I'm going to share the results. Okay, I'll read these out to you, Tom, because I don't think you're able to see them on your end.
Thank you.
Sure. So claims, we have 65%. Public domain data, 65%. EMR, 50%. And non-standard data directly from PACS is 33%.
Just want to comment on this survey. So this is very interesting. So again, historically, before we went to downside risk, our success was predicated on claims data and on EMR data. But it became very clear to us that as we're beginning to take on more and more risk, that we needed to introduce some other data sets, again, real-time data, in order to help support us in our future, not only with our ACOs, but also to support our hospital as well.
Yeah.
Okay, great. I'm going to take this back down.
Okay, great. So you can see the slide again?
Yep.
Okay. Yeah, it's interesting. I mean, it seems like, the most of, clients of ours at CarePort that are doing this type of work are really using multi-dimensional data sources to sort of profile that market. And really, you will answer different questions with these different data sets. Great. So, a couple of characteristics of the data that you will get in CarePort Insight that I just want to draw attention to that I believe are really important is risk adjustment. And this is when you consider the fact that SNFs care for different people, different case mix, different average age, different levels of acuity, that when you just look at an observed rate of something, you can come away with the wrong conclusion about the quality of that provider. And that's why if you're pulling a lot of stuff from Medicare.gov, it's going to be 12 months old, but it will be appropriately risk adjusted. Everything at Insight is going to be risk adjusted as well. And so here, this is an example of two facilities that are in the same market. This is real data. And you can see SNF A had an observed hospitalization rate of almost 30%. So this is, like a really high hospitalization rate. And in the same market, not far, there is another facility where the hospitalization rate is 14%. So you just look at the observed rates, clearly, provider B is the superior quality provider as it relates to hospitalization. When you run algorithms on the patient populations they cared for, though, what you're going to find is that SNF A actually took care of a much more acute population. And this is a little bit of an outlier. This is a very high expected rate of hospitalization, but their patients are older, more chronic conditions. They are going to require more care and therefore more likely to be hospitalized. Whereas when we look at provider B, they're actually dealing with a healthier population. That expected rate of hospitalization is much lower. And so when you take into account the differences in case mix between the two providers, what you'll actually find is that provider A, considering the acuity of their patient population, is doing a better job managing hospitalizations. And so this is when you're building your network, you're going to want to consider that. Else you might make the wrong decision and think that provider B is doing a better job managing hospitalizations. One other characteristics I'll share with you, real-time data. I know Dr. Calderon, you had mentioned it several times. Just to give you an idea of how important this is, one stat that always wows me, and I remember when someone on my team calculated, I had to double check their work to make sure it was true. But if you look at public data and you compare all 15,000 SNFs in the nation, 1 year to the next, the average SNF in the nation, their readmission rate is going to change plus or minus 20%. That is average. So that means, if your rate is 20%, you're jumping next year to 24, or if it was 20, you're jumping down to 16%. So these are meaningful differences in quality over a course of 12 months. And just to illustrate that point again, here's another real provider. Again, I'm using public data. Over the course of 12 months, they went from 29.6% to 22.1%. So from one of the worst in the nation for readmission rates to average. And so clearly, they're making improvements, and you sort of want to recognize that when you're looking at quality in your market. And then finally, and I know Dr. Calderon, you were big on you have a very broad scope. You care about all your patients, and that makes a lot of sense and is important. But I will also say sometimes when we look at the data and we look at the attributions our clients give us, we sometimes find there are differences in our quality measures based off the population we're looking at. So again, some real data that we're pulling from CarePort, where when we profiled the risk-adjusted hospitalization rate of this SNF, all their patients returned to the hospital at 9%. When we look at just the patients they have that belong to an ACO of one of the population directors that's managing patients there, just their ACO population, it was much higher. And there's all different reasons why you will see differences from overall SNF performance to the value-based care population you are looking at. But it's important to just be aware of those changes. And that's something that we are surfacing with Insight. How do your BIPSI patients look? Do they look different than the ACO population or Medicare Advantage? And so something to consider when you're looking at these metrics. Okay, Dr. Calderon, I'm going to pass it back to you to talk about some of the findings you've had with our data.
Why don't we go to the next slide? Let's see what we have here. All right, so some of the things that I just wanted to share with you as far as the tools that I've utilized. So I've already described how we developed the high-performing network. This was a sort of a pleasant surprise. So when we acquired, or we made the purchase for CarePort Insight, the specific purpose was to manage SNF facility performance. But lo and behold, there was this data on our SNF attendings. Some of the doctors that I was familiar with, because we had employed SNF attendings at several of our high-performing network facilities. But then I identified dozens more that independent physicians, physicians that are part of our lease practices, that were doing SNFist work on their own. And so I thought, wow, how can I engage these doctors now that I know that they're doing this work? And working with the folks at CarePort, they helped me put together a very simple dashboard, a simple scorecard, if you will, for our SNF attending. The way I do it is it's those attendings, those SNFists who see at least 25 or more patients in a quarter, want to have a minimal amount of patients in order to make the numbers work. I provide them, again, very basic information. Here are your admits, here are your discharges, your readmission rates by the facility that you're working at, your average length of stay by the facility that you're working at. And then at the bottom, it's how do you compare to the high performing network? So all things go back to those 27 facilities. And this is the aggregate score, the aggregate length of stay, the aggregate readmission rate. How does your performance compare to the high performing network? And this data has been well received, because typically SNF attendings aren't getting any kind of metrics or any kind of data from the facilities that they're working at. So it was just sort of a good way to begin to engage the skilled nursing, the SNF attendings. Another opportunity with this SNF data allowed me to support clinical integration. So what you're looking at there on the left-hand side is just the sort of the Epic background. And what we've done is we've planted a banner that identifies those patients that are part of a risk program. So as Tom said, I don't have the bandwidth to manage each individual patient that's in a risk program. But we want to be able, how can we tackle those individuals, those patients that really need the most attention, the ones that are in a risk program. So we have a banner that we put in Epic that identifies those patients that are in one of our value-based programs. It could be the ACO, it could be one of our Medicare Advantage value-based programs. And we ask our skilled nursing facilities is, hey, look, if one of our value-based patients goes to your facility, we would appreciate it if you would assign them to an Atlantic Alliance doctor. And as part of my regular meetings with them, I identify the SNF attendings where the patients were attributed to, and which patients are part of Atlantic Alliance, which doctors are part of Atlantic Alliance, and which are not. And so this is helping me now to improve clinical integration and supporting our Atlantic Alliance physicians. Oh, so this is another, so I talked a little bit about hospital throughput. So patients that get readmitted certainly represent a challenge for the hospital. It certainly impacts the SNF, but it impacts the hospital as well, perhaps more so. One of the more eye-opening things that I was able to sort of garner from the data is not only when the patient got readmitted, but when they got readmitted. So when I was looking at that bucket, that 0 to 3 day bucket, that told me that there was probably a transition of care issue, not on the part of the SNF, but on the part of the hospital that may be causing that quick turnaround, that quick readmission. And so I wanted to dig a little bit deeper into that. So again, I meet with the skilled nursing facilities all the time. So, well, tell me about the communication. Are you getting what you need? Well, sometimes the universal transfer form is incomplete, or it doesn't accompany the patient. Sometimes it's very difficult to find clinical information in Epic CareLink. especially if you have a lot of agency staff that are not facile in using CareLink. Sometimes we transfer the patients at very late hours. So another data point in CarePort was the time the patient arrived at the facility. And I was seeing things like 11 p.m., 1 a.m., and I actually didn't believe it. I thought it was an error. But again, I met with the SNFs and they validated that, oh no, you are sending patients at these times. You can imagine how disruptive that is. Part of it had to do with just transportation, staffing issues around transportation. So we quickly worked with our skilled nursing facilities and say, hey, look, we know this is our burden, but if you can pick up the patients earlier to avoid that disruption, you're more than welcome to do that. And a lot of them did until we were able to get our transportation staffing up to snuff. But these are the things that the data pointed out to us that impacted readmissions that had nothing to do with the clinical condition of the patient. It was communication, it was the time of the discharge. Other things that we're looking at now, other data points include primary and secondary diagnoses of those patients that get readmitted. Is there an opportunity to establish clinical care paths? So if one facility is sending back a lot of patients with heart failure, do we need to work with them on a clinical care path or send those patients with heart failure to a facility that does a better job? So there's a couple of ways that you can use that information. So very helpful as far as supporting hospital throughput, getting those patients moved along, and so that we could focus on the acute care issues. So this just reflects some of the different reports that I've put together or use cases for CarePort. So developing the high-performing network, development of the utilization and quality scorecards for the SNF facility, developing a scorecard for the SNF attendings, looking to improve communication with transitions of care, again, transportation issues, early readmissions, and making sure that our hospital team is engaged in those review of those readmissions and that they're looking at the root cause of those challenges. Developing clinical care paths for those skilled nursing facilities that may be struggling with a particular diagnosis, whether it's COPD, whether it's heart failure, MI. But I've been able to really accomplish a lot as far as using the different analytics within CarePort. So as far as the goal here to build a high-performing network, so it's about the high-performing network, but it's also more about improving the quality of care transitions. Reducing readmissions, improving reducing the unit cost of my SNFs. So if you go into your ACO reports, there's terrific metrics there or data there on how your overall SNF unit cost per day, cost per stay, SNF days per 1,000. So all of that information is there in your ACO reports. If you haven't had a chance to look at it, take a look at it, track and trend it. But certainly you're still going to need to rely on real-time information to sort of take action on individual inpatients. But we've been able to establish the high-performing network, drive improvement in our SNF performance, also working on selection of the appropriate site of service and making sure that patients are selecting one of our high-performing network facilities. So I had to do a fair amount of education with our discharge planning team about the investment that we made. So these 27 facilities, this is not just a list of random facilities. These are facilities that we have made a financial investment in. CarePort, Epic, post-acute liaisons, SNP attendings. This is all part, this is an investment. So these are value-added services that we are providing and working with these skilled nursing facilities to help ensure patients have better outcomes. That is why you select one of those 27 facilities. Next slide.
Yeah, Dr. Calderon, I'll, just sort of, validate that those investments have paid off. And, one of the trends we pulled out of Insight was the percentage of your ACO populations that are getting into that preferred provider network that you have put so much investment into. And, I will say amongst many of our clients, it's hard to say like what a good number is because everybody has like a different size of their network, right? Like you have a fairly large one, but you're getting 70% of your patients discharged from an Atlantic hospital. The discharge planners are making sure they get to one of these high quality providers. And what I will call out that's somewhat, remarkable, unique about Atlantic is you guys have been extremely consistent in that rate of which you're getting patients to those preferred providers. So always room for improvement, but really like steady, you're getting people into this high performing network.
But again, you want to make sure that 30% that is out of network, you need to engage those facilities as well, because if they are not performing, they are going to adversely impact you. So keep them engaged, keep sharing data, encourage them to share data with you, CarePort, again, to sort of keep them involved in the process. So this is an example of the scorecard that we use. We present two scorecards, a utilization scorecard and a quality scorecard. So again, very, very simple. This is built on an Excel chassis, so nothing fancy here. And you can use dashboards that are already available in CarePort. I wanted to sort of take a different approach. So again, I meet with the facilities on a bi-monthly basis, but we review data on a quarterly basis. So in this example here, we're looking at second quarter 2022, which is the large numbers in the center. The number on the left-hand side is prior quarter performance. So in this case, it would be first quarter. And then you have in the second quarter, they had 61 admits. And then the number on the right-hand side is how they compare, again, to the high-performing network. All things come down to how well you're performing against those 27 facilities. So we look at admits, we look at discharges, we look at the different hospitalization buckets. Again, that 0 to 3 day rehospitalization bucket, if there's cases in there, you want to make sure that your facilities are comfortable with telling you what some of the challenges that they are having, which is why these engagement meetings are so important. There was some reluctance at first for the SNFs to say, you're really not doing this well, because they feared that we were going to take some sort of action against them. Well, I'm happy to tell you that they are more than happy to tell us the things that we're not doing right, which is great, because that's the only way I'm able to fix it. So you've got your readmissions listed there. At the bottom, you have your readmission rate, again, how they compare to the high-performing network. And then you have your length of stay. On the far right, you have the metric definitions, which I pull right from the CarePort report, so nothing to figure out there. Very simple. And this is what we review with the skilled nursing facilities, along with their quality report, as well as the SNF attending utilization.
I'll chime in again, Dr. Calderon, sing your praises. Again, how has this network performed? Similar trend chart. We're often looking at, the 30% of patients that did not get into this network that you've built. What was their performance versus the ones that did successfully go to this high-performing network? And I think in terms of utilization, you'll see that there's about a 2-day difference between a patient, again, risk adjusted, so controlling for patient characteristics, same patient, they get into this collaborative of yours, they spend 2 fewer days on average in a nursing home. And so over, thousands and thousands of patients like you're managing, you're talking almost $1,000 every additional patient that you get into that network. And those are 2 fewer days that patient's not at their home. So again, just another way to illustrate how well, and pretty consistently month over month, your network is outperforming the market in this respect.
And then this is the quality scorecard. Again, we review it on a quarterly basis, even though the quality data is provided monthly. On the left-hand side, you see the overall quality score, and then the 3 components that make up that overall score. The quality score at the bottom, that is what we utilize to not only assess whether you're going to be in the network or not. That's one of the 3 metrics that we use. That is also the only objective data that we put in front of patients as far as selecting a high-performing network facility. So we list the facility, the county, and their quality score. In addition to that, we review some of the short stay metrics, and then we also look at staffing. And staffing has become very important right now. And when we see declines in staffing, that's part of the conversation that we have during our regular meetings, particularly if their admission volume is going up. If the admission volume is going up and the staffing volume is going down, how do we square that circle? That just doesn't make sense to me. So again, we have a conversation about that because there are ratios that they're supposed to maintain as far as staffing for patients.
Yeah. And I'll add, Dr. Calderon, because I know we looked at various different ways that your network outperformed from a quality perspective, but I know one of the ones that jumped out at us, that RN hours per resident day, right? A patient that gets into your network is going to a facility that's better staffed with RNs per patient.
Absolutely.
And so again, you can get the theme. We're always looking at sort of the marginal benefit of building out this collaborative, and the one that we just decided to trend here was the marginal benefit. Every patient that gets into your network, on average, 5% more likely to discharge back to the community safely, right? So again, we could have picked a lot of different measures to trend here, but the patient getting into the network gets home more often safely.
Yep.
Okay, so Dr. Calderon, that was like really informative, telling us a little bit about your experience and how you use CarePort data and other data sources and manage your network. You want to tell us a little bit about, you've shown some success for sure. What's the plan for next year? Where are we going next?
So in all likelihood, we're probably going to make some additional investments in CarePort with some of the additional tools that they have, CarePort Connect, for example. We're also looking forward to some of the newer analytics that are coming down the road. So predictive analytics specifically. So we need to be more efficient. So we know the SNFs are having an issue with staffing, so are the hospitals, so is the ACO. So we have to look for ways to be more efficient. So having predictive analytics as to which patients that we should be focused on, which ones are the likely ones that are going to get readmitted, which patients are hospice eligible, if you will. And we really need to sort of nail down a goals of care conversation, make sure that we have that pulsed, make sure everyone is in agreement on the hospital side as well as the SNF side as to what the family's wishes are. So that's a very important piece for us. The other thing that we're really driving with the skilled nursing facilities is, what are you doing in your shops to support treatment in place? So we're still not at, the transfer volume is still not at pre-COVID levels. So my message to them is, well, these are the patients you have, keep them. How do you, what are you doing to prevent those readmissions? Because there's no guarantee they're going to come back to your facility if they get readmitted. So are you looking at things like dialysis in place, which is huge. Right now we have one facility that does dialysis at the SNF, but think about the elimination of transportation costs, the elimination of facility fees, the elimination of the knee-jerk response to send the patient to the emergency room because they're in a facility that's not familiar with the patient. So using technology, a variety of different things, they need to start embracing those things at the facility. I'm going to stop because I know we're running out of time. So
Yeah, that was great. Should we take some questions? We still got 5 minutes. Open it up for some Q&A.
Sure. Yeah, we'll get to a couple. We probably have times for some really brief questions. We have a ton. So, and I just want to remind everyone, if we don't get to yours, because we have a bunch and we definitely won't get to all of them, we will respond with an email. So go ahead and ask your question if you got it. We'll get back to you. But I'm going to pick a couple just at random here that we can maybe get some quick replies to. The first one is, have you found geographic location as a factor in SNF performance, like rural versus metro locations?
Really haven't had that much experience. We're more function in a suburban type of community, so that may exist. And there's certainly regional differences and nationwide differences as far as SNF utilization is concerned. Where we see the differences is really on the acuity of the patients that a facility will take. So if they're taking Medicaid pending, not all facilities do that. If they're taking behavioral health patients, again, not all facilities do that. Then we see some variations as far as utilization, and we have to make accommodations for those SNFs because they're servicing the needs of all of our patients, and so they need to be a part of our network, even if they're not performing at goal.
And Dr. Calderon, I'll add, since I know your view is like within your market, you're really familiar with your providers. I'll say from market to market, going across states, across the coast, some of the two very much so. What is a good benchmark for your market, Dr. Calderon, would be terrible in others, and vice versa. It can look very different. I'll tell you two that we've seen really big differences: staffing, how badly nursing homes have been hurt by staffing crisis.
Absolutely.
It really varies region to region. And then length of stay. Different practices in length of stay, which is probably a function of how much managed care is in each geography. But those are just two that jump out at me. It's really different from market to market.
Great. I think we have probably, unfortunately, only time for maybe one more question. Again, we had a ton coming in, but don't worry, we'll get to yours through email. But this last question is, how is Atlantic using the liaisons to proactively manage patients in SNFs using CarePort?
So the PAC liaisons have access to CarePort. They're able to focus on those patients that perhaps they're getting to a goal length of stay. So those are the ones that they'll start asking questions about within the skilled nursing facility. Again, efficiency. Where do I need to focus my attention on? Oh, this patient's already had a readmission once already. Likely going to have one again. So let's focus on that individual when we have our UR rounds. And our PAC liaisons, they work virtually. They work at the facility. Some of them are allowed to go to the bedside. So there's a lot of ways that they're able to engage our SNF partners.
Great. Well, guys, unfortunately, that is all the time we have. I wish we could probably talk about this for a long time, but we've got to wrap up. We're out of time. So as we conclude, well, first of all, I want to thank you guys. This was a fantastic presentation. I know I learned a lot. There's a lot there, obviously, and you guys are clearly very passionate about it. So wonderful presentation. As we wrap up, I'd like to encourage everyone to visit the CarePort exhibit booth at vbcexhibithall.com. And you can see it there on the screen. If you go to vbcexhibithall.com, you can find the CarePort booth, and the slides will have a link directly to it as well. But here's where you can see a lot of their resources, what they're doing, interact with their team, kind of see what they're doing in the value-based care space. So a lot of cool things here. Also in the library at vbcexhibithall.com is where you'll be able to get the recording. So even if it's a couple months later, you're like, yeah, let me take a look at that again. I am going to send it out, but you can find it there. And that said, again, I'm going to send out the link to the recording afterwards. So if you missed the first part of it or the whole thing, you should be able to review it later. And then finally, if you want to reach out to any of the team at CarePort, feel free to do so. Let's see. Tom, can I get you to go to that last slide?
Oh,
Oh, we had a thank you slide. We can go to that very first one. There you go. The thank you. There. Okay. Anyway, there you go. So yeah, feel free to reach out to CarePort directly, or you can reach out to me. I'm happy to facilitate an introduction with them. Thank you all so much for coming. Have a wonderful rest of your days. Bye-bye.
thank you.